Okay, moin und shalom. Hello, everyone. Welcome back to another GIHF-AI Roundtable. Today we will discuss health data use policies in Israel and in Germany to shape the future of healthcare together. So it's not less than what we do here at the German-Israeli Health Forum for Artificial Intelligence. Many of you have been with us more than once, so sorry if this is not new for you, but for those, I see some faces that haven't been with us yet. Just to remind all of us, this is a program hosted by the European Leadership Network, by ELNET, the premier organization to connect Germany, Europe, and Israel, vice versa. And we established this program in 2021, so it's already the second year, and thanks to the funding and the support of the German Ministry of Health, and also thanks to the support and a very close collaboration with the Israeli Ministry of Health, we are delighted of hosting this series of roundtables to discuss current policy issues, to exchange thoughts, ideas, to learn from each other, and also, most important, to derive policy recommendations that are useful for both countries and beneficial for both ecosystems in the health sector. So this is already the second roundtable this year. If you missed the first one, have a look at our website to have a look at the report and also the policy briefing that we published before. And it is also the second roundtable on regulation. As you may have seen on the website or remember from the last roundtable, we have three work streams. Regulation is one, technology and security is another one, and communication and trust is the third one. And all these three work streams will be combined in our annual conference. Last year, it took place at the Tel Aviv Medical Center, the Irilov Hospital in Tel Aviv. This year, on September 5th and 6th, we will, all of us, hopefully, will meet in Essen. So just 1.5 days before the Big Bang Health, a beautiful and marvelous conference on all topics in digitalization of health will be hosted in the Colosseum in Essen, so in the industrial heart of Germany. And right before, in the same location, we will actually start and take the stage first with our second annual conference of the German-Israeli Health Forum for Artificial Intelligence. So if you do not have booked and made your arrangements yet to be with us in Essen, reach out to us if you need any advice, and just go ahead, and we will be delighted to welcoming all of you for the conference in Essen. Let's get back to why we met or why we meet today. So again, we will have two keynotes, two inspiring keynotes from the Israeli and the German Ministry of Health regarding health data use. And it's my very pleasure to welcome Yoel Ben-Or, the head of policy from the Israeli Ministry of Health. Good to see you. Welcome back, Yoel. And second, to welcome Marejke Talea Tammen, Senior Policy Advisor at the Federal Ministry of Health in Germany. Marejke, good to see you again. Thanks for taking the time being with us. Yoel will start with an impulse on health data regulation, current policies in Israel, which will rightly be followed by the impulse from Marejke, speaking about Germany's digitalization strategy for health and care. So we are very curious on your keynotes. Afterwards, we will have, as usual in our roundtables, a workshop where, of course, all of you, no matter if you're a speaker or participant, if you're here for the first time or a regular guest, please join us in an interactive discussion. Yoel and Marejke will be with us, and we will also, in addition, welcome Tamar Tavori, Special Counsel Anon Tatmolevi, and Professor Dr. Frushina Molnar Gabor, the Chair of International Health and Medical Law and Data Protection Law at the University of Heidelberg. So also, thank you very much, both of you, for joining us today. But before we start with the interactive workshop session, let's give the floor to our two keynote speakers. And if I'm not mistaken, Yoel, you are the first. Please, the stage is yours. Thank you very much. And again, welcome everyone.
Thank you, Carsten. It's wonderful to present here again in this wonderful forum. It's a subject that we are all governments, all Ministry of Health are dealing with are the same these days, I guess. And it's really inspiring to hear some thoughts from Germany and from other participants here. So thanks again for the opportunity to share our current thinking. So I have some small presentation. Okay, so I want to try in the next few minutes to give you the main efforts that we are trying to establish in the coming year in our regulation, in our policy, and then talk a few minutes about how these main vision, main policy goals are being. Give you an example how these goals should be subject to a lot of concrete and very small questions that are currently on our table. So try to move from the vision to the concrete questions. And obviously there's a lot of questions, but I'll just try to give you one example. But let's start with the vision first. So I think the vision is very similar in a lot of digital health strategies, and don't think there's something unique in this statement. We're trying to get to a world in which everyone can securely access and use the right health data when and where they need it. Obviously, if they have a legitimate purpose to use this data. And this is the vision. And currently in the next year, we are talking about three main efforts to it's an ongoing vision, but these will be the three main efforts in the coming year. And the first is excellence in data quality. Well, Israel is very proud for starting digital health about 3 decades ago when we adopted EMRs. But that means that because we started early, the clinical terminology is outdated and local. We are in a mess in terms of the terminology we use. Every health organization, when we started 3 decades ago, there was no regulation. So every health organization, sometimes two departments in the same health organization, are using different terminologies. And this is obviously something that we want to change. And that means that the Ministry of Health needs to have a new role in the ecosystem to support the change to SNOMED CT, which is the main terminology that we're trying to pursue, but also to management national catalogs and enforcement of the use. So we started in 2022 in some incentives program to health organizations to implement SNOMED CT. But if we're looking forward to 2023 and 2024, then incentives for health organization will not be enough. We understand that we have to have regulation in place, that everybody will have to use this new terminologies. So this is one main effort. The second is connecting the dots, FHIR, Fast Healthcare Interoperability Resource. The last roundtable discussed it in deeply. Here I'll just talk about it in a few points, is that we also started with some incentive program in last year and gave health organizations some money to implement FHIR. That the idea behind this is to have much more seamless integration and helping health organizations to exchange data much faster. But also here we understand today that incentives are good, and there was a lot of successes. And if we'll have time later, I can tell you more about very interesting projects that are going on in this domain in Israel. But if we really want to push forward, then regulation also has to be in place that every health organization should adopt FHIR. The benefits for every stakeholder to adopt the standards is much bigger if everyone is doing it. This is what standards are meant for, right? Because you want to have the network effect that everybody is working with the same standards, and that cannot be accomplished without regulation. So this is the second tier of our work in the next regulatory route in the next year. The third is after we will accomplish, hopefully, in terms of regulation, it will take a lot of time to implement in the field, but in the regulation, the technology aspects of terminology and FHIR, then the other aspect is who controls the data. And letting patients decide with whom they want to share the data. So we started in 2014 with a closed network that we are very proud of. It's called the Tammen, which can enable data exchange between HMOs and hospitals in Israel. And we're very proud of this system. It works very well, but there's a couple of limitations. The first is that it's a closed network. That means that the government is deciding who gets to connect to this network, and data is being transferred without consent. According to the Israel regulation, you're allowed to transfer data for clinical purpose without consent of patients. But that means that the government is quite conservative about who can get connected to this network. Because it's without consent, we cannot just get everyone connected. Service providers are becoming much more decentralized. There's a lot more suppliers of data and a lot of consumers of data that can help with providing services to patients. And we cannot rely only on a government-owned network that that the government decides who gets to join. And if we want to open the network, then consent should be also a possibility, because then patient can decide who's getting to join, with whom they want to share. So this is one angle of it. The other is the fact that it's one network. It means that there's only one vendor that is running it. And if we look ahead at digital health possibilities that we have, we would like to see much more technological tools that are available to patients and to providers. And that also means that if you want to connect much more tools and not just being dependent on one vendor, then also consent should be implemented in the infrastructure that patient can decide with whom they want to share their data. So going to the open network when patient decides with whom they want to share their data is the next move. We're not going to abandon the closed network. We think it has a lot of advantages. And as I said, we can and we should share data without consent for clinical purpose when it can be done. But if we really want to open up the network, we have to implement consent in the system. And so this is like the three main agendas for the coming year. And I want now to give you like a very short example if we want to try to think of the dilemmas that we are facing when we think of consent as something that is very important to put in the infrastructure. So if we talk a little bit on consent, so the problem with consent that it sounds easy, but it's not an easy task. Consent can be with multiple aspects, different option how patient can give their consent. There could be time differences, and there could be different framework when you want to apply consent. So I want to really briefly touch on each of these points. So the first thing is multiple aspects of consent, right? You can consent to specific health baskets, my observation, my medication, etc. You can think of the depth of data history from the last year, from the last 2 years. You can think of consent from which data holders you want to give access to. And you can think of it as a one-time access versus a continuous access. So there's a lot of aspects of the consent. And if you try to implement all of them as options that are being given to the patient, you get a metric that is not feasible, right? Like just think of this example, give one-time access to my medication during the last year from hospital A and continuous access to my observation from the last 2 years from hospital B, etc. That's becoming ridiculous, and you have to give patients the ability to decide what their wish to consent, but to understand what they're doing, but in a much easier way. And if we're thinking about how are they giving these options, so each one of these aspects can be managed differently in the way patient can decide. You can do an opt-in for each box. So if we think of data holders or health baskets, then you can say, I want my observation or I want my medication. It could be an opt-in or an opt-out. But you could also say, okay, the service provider asked for these 10 health baskets. You just need to say all or not, yes or no to all 10 of them. You cannot decide about each one. So this is another aspect of this dilemma. Another one is you want to think of time differences between consent and service, right? Let's say I got an appointment in the next 2 months in some hospital, and they asked me to give consent to share my data at the moment I had the new appointment, but they want to use the data in 2 months when I really will go to the hospital. And in these 2 months, maybe there's a new data source that is being added that I was not familiar with at the time I gave consent. So you can either say that the new data source will be added automatically, or you can ask the service provider to ask again for consent because there's a new data source. So this is another aspect of this. And the last one I want to touch on is that all of these dilemmas are not, or should not, from our perspective, being decided as a one-size-fits-all, because it depends who is the service provider. Is it the health service provider, or maybe some health tech application that I want to use for my well-being? And it's also relevant, what is the type of the data? If I'm sharing the regular health data, which is obviously always sensitive, but there's also extra delicate data that is maybe psychiatric data, or things like that, that can be presumed about by most of the patient maybe as more sensitive. And all of these questions should help us decide about this complex metric of consent. So this is something that we're doing now there's a lot of discussions about it in Israel. And we hope that in the coming month we have more answers. But just to give you I won't go over it, but this is like how it looks if you're trying to answer all of these questions. And this is just an example. You can, if there's 10 people in the room, there will be 10 different answers to this table. And if you want to get the consensus and go to the parliament with in the coming month with how this can actually be implemented in the health system. And you need to remember that this is a new procedure that patients in Israel are not regular. They never gave consent to anyone. Nobody asked for them to share their data. This will be a new procedure if we will succeed to pass the new law. And in order for patients to being able to use this new procedure, it should be simple and something that will really everybody will understand how it works and how it will hopefully benefit them in the health system. So there's a lot of other dilemmas, but I think I'll stop here and thank you very much.
Toda rabba. Thank you very much, Yoel. So we see consent is definitely not an easy task. Thank you very much for the Israeli perspective. And without further ado, where do we have there? There we go, Marejke. The floor is yours for the second keynote.
Thank you, Yoel, for your input. And thank you, Carsten and Leo, for the introduction, and also warm welcome from my side. Unfortunately, I have some technical issues, but luckily Leah is helping me out and she will show my presentation. I hope it works. All right, so you should see the first slide right now. I hope you can see it. Okay, perfect. So yeah, as Carsten already said, I am talking about the German digitalization strategy for health and care today. Next slide, please. Yeah, perfect. So what am I going to talk about? I will start with a very short introduction and I will explain the starting point of our strategy's development. Then I will come to the content of the strategy. So I will explain our goals and objectives, as well as the measures or the planned measures to achieve those goals. And then we will look at what that actually means translated into numbers. And finally, we will take a quick look at the governance approach and strategy implementation. Perfect. Yeah, so how did we come to develop a digitalization strategy? The starting point was actually the coalition agreement, because it obliged us to develop a digitalization strategy, which will be constantly developed and has a focus on solving problems in healthcare provision and on the user perspective. And yeah, since we have a very complex healthcare system in Germany, so you probably know that we have 96 insurance companies in total. It was very clear from the outset that we could only develop this strategy with the close involvement of all stakeholders. So we not only involved physicians and, for example, pharmacists, but also patients, people in need of long-term care, and also their family members. Next slide, please. Yeah, so here we can see exactly how this was done. So we started with a kickoff event in September, which was followed by some expert interviews, an online survey, and also specialist forums. And at the end of last year, we were ready to formulate our vision and our strategic goals. And in March 2023, so only 3 months ago, we published our strategy and our minister presented the strategy at the Federal Press Conference. Next slide, please. Thank you. Yeah, so this graphic actually shows the heart of our strategy, or yeah, it shows the main topics. What we can see is a clear focus on people, so they're in the middle, and the people should have the opportunity to use benefit-oriented technologies and applications. But in this healthcare ecosystem, we also have 2 other aspects. So the people-centric healthcare processes and also the importance of high-quality data. So what exactly does that mean? Yes. One more. Yeah, perfect. So for one thing, we want to achieve that the telematic infrastructure and the EPA, so EPA is our German electronic health record, become the individual healthcare platforms. The reason for that is that our EPA has hardly been used by patients so far, and that is why we want to introduce the opt-out model. This means that every citizen will receive an EPA as long as they do not actively object. Plus, also the electronic medication plan will be integrated into the EPA. Yeah, that's right. And if we look into the near future, we also want to achieve that the EPA enables individually tailored prevention and healthcare services. Okay, next slide. With regard to health data, we want to achieve, first of all, higher quality, fast availability, and also better interconnectivity. But however, we also know that this requires a paradigm shift, because in Germany, we are always very quick to say, oh, that's going way too far and we have to protect our data at all costs. But we often forget that data also has a great benefit. And we actually want to emphasize that. And for that, we need more legal certainty in the relationship between data use, data protection, and data security. Yes. Then, in view of demographic change and also the shortage of specialists that we have in Germany right now, especially in rural regions, telemedicine is becoming increasingly important. And actually, the corona pandemic was or acted as an accelerator here in Germany, because in the entire year 2019, there were only 3,000 treatments using telemedicine. But in the first half of 2020, there were already 1.4 million. So for Germany, that's a lot. And this is, of course, also related to the regulatory changes that we have made during that time, because we lifted the 30% limitation. And since we want to learn from this, we will finally lift the limitation on telemedicine during our legislation process. Another important measure is that we will set up a contact point for assisted telemedicine by non-physician healthcare staff. So, for example, in pharmacies and health kiosks, plus the establishment of digitalized or digital disease management programs. That is also on our agenda. Next slide, please. Yeah, of course, we also want to make, or we have to make some changes in the area of care, even if I'm only touching on that subject very briefly now. But for example, we want to set up a competence center for digitalization and care. And we also want to achieve that digitally supported interoperable care documentation becomes the standard in care. Next. Yeah, so what does all this mean in figures? With regard to the EPA, this means that we want to ensure that 80% of all people with statutory health insurance have an EPA by 2025. And by the end of 2025, 80% of these users will also have a digital medication plan within their EPA. In the case of telemedicine, that means that by 2026, at least 60% of underserved regions will have a contact point for assisted telemedicine. And yes, in terms of data, we want to achieve that at least 300 research projects are carried out using data from the Research Data Center. It's called the Health Data Lab by the end of 2026. And another important factor is, of course, the aspect of communication. So by 2026, we want to achieve that at least 80% of all communication processes will be carried out paperless. Yes, thank you. Yeah, to achieve all these goals, of course, we need a regulatory framework. That is why we have two laws in the pipeline right now. We have the Digital Act and the Digital Health Data Use, the Act on Health Data Use. In the Digital Act, we primarily want to regulate the opt-out EPA, and we also want to achieve that the e-prescription becomes the standard, as well as we want to achieve a binding commitment for uniform standards. The challenges we are facing here are, for example, that we have we have short time, so the implementation has to start very quickly, and there are also other transformation processes at the same time. Next slide, please. Yeah, in the Act on Health Data Use, the focus is primarily on improving the usability of data for both care and health data, care provision and research. Then we have to create a decentralized infrastructure for health data, and we want to create the conditions for a data-driven learning health systems. Challenges here are that there are also negotiations on European level concerning the European health data space at the same time. And as I already said, there are very restrictive interpretations of data protection in Germany. So we are still having discussions on these subjects. And in terms of timing, one slide back. Yes. Yeah, in terms of timing, we actually move in lockstep with the Digital Act and the Act on Health Data Use. So both drafts are currently being discussed by the ministries, and we hope that the laws can come into force in 2024. And yes, that brings me to the end, and I look forward to discussion. Thank you.
Thank you very much, Marejke. Well, what can I say? I really find it striking to see how much progress is in the making. Many of the topics you elaborated on were also among the discussion points of the German-Israeli Health Forum in the past. So I just take it now for the gratitude of the team that we maybe helped here and there to inspire. And by team, it's now my very pleasure to hand over to my dear colleagues, Lea Ledvon, who is the GIHF-AI program manager based here in Berlin, and also to my dear colleague Genoveva Barrios, who is our program manager for innovation in our Israeli office in Tel Aviv. So Lea, why don't you pick it up from here so that we switch over to the interactive workshop part now. And again, thank you very much, Yoel and Marejke, for being with us and staying with us for the workshop part.